Hello there, this is John, and this is chapter 33, the anatomy of the eye, face, and neck, and of course, the potential injuries to those areas. That's the eye. I kind of hope you figured that one out already, but that's the eye. Here's a cross section of the eye. They call it the globe. You can kind of see why. It's kind of globe shaped. And the shape is really, really important. If you hadn't thought about this before, the eye is essentially a camera and it has sort of what you would call a focal length. We have a lens, an interior lens that the light passes through, and the distance from that lens to the back of the eye is really important to maintain because if you don't, you have blurred vision or sometimes even no vision. So you can see when someone has an injury to their eye, to the globe of their eye, and it changes its shape, it can actually affect their vision temporarily or even permanently. So we have this what's called a posterior chamber, and that's the vitreous humor in the chamber. It's kind of that big red area in the back there. Um, the vitreous humor is kind of a jelly-like substance. It holds the eye in that shape it needs to optimal viewing, so to speak. There's actually an anterior chamber as well. It's kind of behind the pupil. It's like this long, thin chamber, and that's filled with what's called aqueous humor, and that's a liquid. It's not a gel. It's more of a like a watery substance. The aqueous humor, if it were to be lost due to injury, it does regenerate over time. Unfortunately, if you lose your vitreous humor, which is that jelly-like substance that gets squirted out from an injury, that does not regenerate, and the shape of the eye is lost, and more than likely your vision is lost in that eye. You can see that there's the sclera. The sclera is the white part of your eye. The iris is the colored part, the blue or green or whatever, brown eyes, whatever you might have. And of course, the pupils you're already aware of, and the lens that the light passes through. You also notice there are muscles attached, and those muscles are attached to the bones in the eye socket or the eye orbit so that the eye can move left, right, up, and down. And then both eyes have what's called consensual gaze. So when you look to the right, both eyes move exactly the same. They go to the right, up, down, whatever it might be. If someone loses their consensual gaze, they get a blunt force trauma to the head or injury to the head or face, and you notice that the eyes aren't tracking together equally, that's a sign there's some type of damage to the eye socket itself, a bone, maybe broken bones, or torn ligaments, torn muscles, things like that. So facial injuries. You look at these two people right here, and I always think of three things when I encounter people with injuries to the face, the scalp. Is first is do they need C-spine? More than likely, I would think you'd agree these people need have you're gonna have your partner come up and with their permission, of course, if they're awake and alert and able to, if they have expressed consent and all that, have your partner hold inline stabilization of the head and neck while you're doing your assessment. Then I'm thinking about, okay, do they have any kind of head injury, brain injuries? So the best way to tell that, of course, is their mental status. If the brain's been affected with a concussion, a contusion, a laceration to the brain, they're going to have some type of change in the mental status. Confusion, disorientation, unconsciousness. They might not recall the event, which is another sign of like a mild concussion. And then, of course, because the head is so vascular, there's so much blood in the scalp and the face and all that. If they have internal bleeding, like for instance, if there's a fracture to the bones, especially the cheekbones, you can get blood leaking into the sinus cavities and then down to the back of the throat. Now you've got an airway compromise. And so those are the three things I really think about when I'm looking at someone's facial injuries. Do they need C-spine? Do they have a brain injury? And are there any airway compromises with this? So here's a picture, of course, of the skull itself. You can see that the zygomatic bone, the nasal bones, they're pretty fragile bones, fairly thin, hollow bones. You'll notice that between the zygomatic, the nasal bone, the frontal lobe of the cranium, the maxilla kind of makes up those eye orbits that the eyes sit in, and they're attached to by those muscle groups that allow that movement, that consensual gaze. The maxilla is the fixed portion of your jaw. And of course, the mandible, the lower part, is the flexible or movable portion. Usually with patients, once I've stabilized them and I've got the ABCs taken care of and I got the C-spine going and this person now is somewhat stabilized and I'm in my secondary assessment, what I'm probably going to wind up doing is I'm going to palpate their facial bones, feeling for any instability, tenderness that or broken bones could mean some type of bleeding down the back of their throat. If they're awake enough, I'm going to have them open and close their jaw to see if their teeth align. So the teeth should line up as you normally do. If they're out of place, it could mean a fracture or dislocation to the jaw. So this poor little guy, I don't know what happened there, but it doesn't look good. This is a picture of my neck. I actually peeled the skin off the side of my neck for you. I glued it back on with some crazy glue, so it shouldn't look too bad. But what you can kind of see with all this is it's kind of a busy place. It's got all kinds of really important structures in there, like the trachea is a little important, I guess. If someone were to get punched in the throat and collapse their trachea, of course they wouldn't be able to breathe. There's a spinal cord, there's a spinal column, there's large blood vessels, there's carotids, there's jugular veins, and all that great stuff. And it's really not that well supported structure. You have this, 8 or 10 or 12 pounds of head sitting on this thin little neck. And if you were to fall and hit your head and wrench your neck, you could have, as you already know, a spinal cord injury and other types of injuries. If there's penetrating trauma to the neck, like a gunshot wound or stabbing, you can see what structures could be involved. So anytime there's injuries to the neck, we're concerned. We want to investigate these injuries. So with assessment for all this stuff. So we're talking about facial injuries. Now, remember, we've already taken standard precautions. We already have somebody holding inline stabilization. We've controlled any uncontrolled bleeding. We've addressed as best we could their airway. We're going to ask somebody, the patient themselves, if they can answer our questions, or witnesses, bystanders, family members. We want to know sample questions. When it comes to sample questions, of course, obvious is what the heck happened today? Why did you fall off your bicycle? How far did you fall? If the guy got hit by somebody, with what object? Was it fists? Was it a baseball bat? What were you hit with? And then once we're getting into the actual assessment of the patient's condition, if they have eye injuries like you see here, I want to know if they can see out of their eyes. So, hey, how's your vision doing? And I know this is going to sound really dumb, but I've had patients who tell me that their eyes are blurry since the accident. My very next question, and I know this is going to sound stupid, my very next question is, do you wear glasses? And yeah, I wear glasses. And I find the glasses like laying on the ground or laying on the floor of the car. I put the glasses on them and their vision's much better. So I know it's a dumb question, but you're going to encounter that. So find out. But again, if this person normally has, clear vision and there's been vision changes after the accident, even with or without glasses. I mean, if the person doesn't wear glasses and their vision changes, that's one thing. But if they have glasses, you put the glasses on them and they still have vision changes, that again is indicative of possible globe or eye orbit injury. Our biggest concern, of course, is penetrating trauma to the neck, like you see with the pencil right there, but also strangulation, self-inflicted or by another person or by accident, or some type of blunt force trauma to the anterior portion of the neck. So foreign objects to the eyes. So the most common thing I encounter out there is with traffic accidents when someone's car gets in an accident and the windshield shatters or the side windows shatter or even the back window shatters. This is all safety glass, and even though these windows they're designed not to break into shards that are sharp to harm you, they do leave a lot of this glass particles floating in the air inside the car. So people get glass in their eyes, these little microscopic bits of glass in their eyes. It's very irritating. They get metal shavings as well in their eyes. So if you have someone who has glass in their eyes, metal in their eyes, or they have a laceration to their eye or some type of injury, blunt force trauma to their eye, we really want to just cover both eyes with a light dressing and then wrap gently to cover both eyes. Remember that we have consensual gaze. So if we have an injured eye, like the guy with the fishhook in his eye, we don't want that eye to move. So if we only covered one eye and the other eye was still able to see, that as that eye, the good eye, is moving around, so is the bad eye. So we want to cover both eyes and then wrap those up gently. Don't put a lot of pressure on the eyes, especially if it has a fish hook in it or some kind of serious injury. We want no pressure on that. When it comes down to flushing eyes, I know you guys, we talked about like chemicals and liquid chemicals versus dry chemicals, brush and flush versus flush. That's kind of a different thing here. If it's purely just dust, and you really is just some dust or some light sand, if the person wants to flush their eyes, well, then that's fine. But again, if you're concerned or you have any kind of qualms about doing that, just suggest to them, let's just cover both eyes. Let's get you to the hospital. Let the doctor look at your eyes before anything happens here. So the eye orbits, that's the bones that make up the eye socket. Again, if the eye orbits are damaged, so there's a broken portion or the muscles have been torn away from their attachment points, you'll see with the upper picture there, this person no longer has this consensual gaze. And this is telling you that eye has been disconnected essentially from its support system, and it can't follow the other eye now. The gentleman down below has quite a bit of swelling to the eye. That eye, I wouldn't even bother opening to look. He probably wouldn't even want to let you do it anyway. I would just cover both eyes. In both cases, I'd cover both eyes with, in this case of the swollen eye, I'd probably use some kind of Dixie cup or some kind of eye cup, cover both eyes, wrap it up with gauze, and then transport this person to the hospital. Now this is a soft tissue injury to the eyelid. You'll notice that if you look at the eye, the globe itself, that the iris looks intact. There's no bleeding. There's no discoloration into the iris or the pupil. Also, the sclera, the white part, is also pretty clean. So I don't see any injury to the actual globe of the eye. So this is purely just a soft tissue injury around the area of the eye. And as long as they have consensual gaze and everything's moving just fine, the vision is great. This is purely just that. So then you'd apply direct pressure with some kind of gauze to stop the bleeding, and then an ice pack to reduce the swelling and the blood loss. If you think that the globe of the eye has been injured in any way, lacerated, scratched, impaled, whatever it is, no ice packs. We do not want to reduce blood flow to the eye when it's injured. We want to promote it. So the only time you apply ice packs is if it's purely simply a soft tissue injury. So this is the actual globe itself. So now you have penetrating trauma to the globe itself. In the upper right, that goo is coming out. That's the aqueous humor from the back chamber, the posterior chamber of the eye, and that's oozing out. The person on the other side here, some kind of staple or something in their eye. These are all both really serious eye injuries that can lead to vision loss or the loss of the eye. In both of these cases, we're going to cover these with some type of eye cup, or again, I use foam cups, like foam coffee cups. You can cut them to whatever shape you want. Put them over the affected eye so there's no pressure on that eye, no pressure on that staple. Cover the other eye with a dry kind of gauze, and then take some roll gauze, and then wrap all this up and get them to the hospital. Chemical burns to the eyes. We talked about, again, the flushing. So this is just continuous flushing all the way to the hospital. Usually if this is an industrial site or some kind of school, chemistry center, they're going to have the flushing system there where they're probably immediately going to take the person over to the sink and they're going to flush their eyes. So probably they're already doing this by the time you get there. The only big complication here for us are the contact lenses. Most people now, from my understanding, wear soft lenses, contact lenses. you can see the potential problem here. If the chemical got between the contact lens and the patient's eye, maybe the flushing might not get the chemical out as readily, so maybe the burning might continue. It's hard to say. Your book talks about taking the contact lenses out. I guess you could do that. I would be reluctant, in all honesty, to do that. And I'm sure those of you who have worn contact lenses or wear them now, I can imagine you've probably gone into the pool or you've gone swimming in the pool, the ocean, and in the process of you open your eyes and one of your lenses just kind of floats away. So my experience has been with contact lenses is if you flush somebody's eyes with copious amounts of water, there's a good chance the lenses are going to kind of float out or float to the side or get, it shouldn't be a big problem. I'm reluctant to really remove someone's contact lenses. But, again, it's your choice. Maybe contact medical direction, ask them. Obviously, this person didn't follow his mommy's. You remember mommy said, don't run with sharp objects. Of course, obviously you need to stabilize that screwdriver. You don't want to actually touch the screwdriver because if you're trying to wrap the screwdriver with gauze, it's moving, inside his eye socket, causing more damage. So consequently, we'd want to get that Dixie cup again and cut it to shape because it's a foam cup. Cover that, and then wrap everything up both eyes and all that great stuff. This would be trauma center criteria. It is penetrating trauma to the head, neck, or torso, so it would go into a trauma center. If this person has an extruded eyeball, like you see in the picture right there, this is, I've had a couple of these in my career, and they were both related to gunshot wounds to the head. As the bullet enters the skull, the expanding gases from the cavitation just kind of push the eyeball out. Now, obviously, this guy's got more problems than an extruded eyeball. Go figure. And you might not even address this en route to the hospital, but it can also happen with when they get hit in the back of the head, blunt force trauma. So again, if this person has more serious problems, again, you might just, at some point in the call during transport when everything else has been done and all the good stuff's been done, get that eye cup, get that Dixie cup, place it over the affected eye, and then cover both eyes with that. But again, someone got shot in the head, probably not a super high priority. People do lose teeth in trauma. They'll literally be punched out of their mouth. It's important if you can to find them. If the tooth is intact, if it has the root and the whole thing's intact, bring it with you to the hospital. Bring it with you to the hospital anyway, I guess. But bring it with you to the hospital. Put it into a cup of saline or some type of sterile water, whatever it might be, and get that to the hospital because these can be replaced. I've had trauma patients have lost teeth. I've handed the teeth to the trauma surgeons, and they just stick them back in the sockets. It's just they know where they go because they're trauma surgeons, right? But if you can find this person's two teeth, and the doctor can put them back into their sockets, you just save this guy probably $8,000 or $10,000 in medical bills to have those have teeth replaced. So you save the person a lot of money. So don't forget those. In objects impaled in the neck or the face like this, you can see in this case if this stick were to go all the way back and actually impinge on the epiglottis, and the epiglottis now is resting on top of the trachea, this person can't breathe at all. You have to pull this thing out. And remember, have your suction ready, have some gauze ready, put it in their mouth to control the bleeding. It's going to be quite a bit of bleeding. Same thing in the neck. If this is in the neck and it's actually blocking the trachea completely, you can remove these on standing order. If the person can still breathe, you leave them in and you stabilize them to a trauma center. Again, this is trauma criteria. Injuries to the neck. So open injuries, of course, lacerations, punctures, closed injuries, we blunt force trauma like a strike to the trachea. Strangulation is really a common call that we go on, and there's various degrees of strangulation. They're all serious. There's the simple thing is someone just grabs someone around the neck and throttled them to the point where they're hanging from a rope. In all cases, these people should be seen at a trauma center. Even if someone just says, "Well, he's choked me for a couple of seconds," that's enough to cause eventual edema, swelling, and occlusion of the airway. So all strangulation patients should be seen by a physician, be evaluated, um, and, uh, and observed for at least 6 or 8 hours before they're allowed to leave. We have a lecture on bleeding control, but we have this stuff called combat gauze or quick clot. If you have a serious laceration to the neck, you can't control the bleeding. Uh, in some cases, you could pack it with that as well. Direct pressure usually works in most cases. Really concerned about the fact that if with the open neck wound, the external jugular vein could be lacerated, and because the vein it pumps at a very low pressure, and the blood is pouring down from the cranium down back to the core, back to the heart. If you lacerate that jugular vein, you could get air into the jugular vein, creating bubbles, and those bubbles could rise up into the brain, causing a stroke. So if you have someone with an open neck wound, like you see in this picture, or something similar, you're going to want to cover that with your gloved hand first, and then you're going to want to apply an occlusive dressing to prevent air from entering that wound. So our biggest concern is not so much blood loss, it's more keeping the air out of their venous system. And of course, it kind of does both things anyway, right? So it's going to stop the bleeding and it's going to keep the air out. And we're done.